I thank Dr. Dega Narayan Reddy to give me an opportunity to come here and speak and meet my old friends. When I say old, they are not old, they are just friends which are old, not the people. And before I begin my presentation, as there were a few questions which very kindly Dr. Venkataraman thought that I would be answering, I'll just touch upon the first question that was about testosterone in women. And there was a comment from, there was a talk about sexual health is a reflection of testosterone. So that is not only true for men, it is also true for women, because testosterone is also produced in the ovaries, which not many people know. And the second is that you would know that women who are athletes, who are sports persons, they have an increased appetite. They are supposed to have increased appetite of sex. Not all, but then that is where it is. And those who are not physically active, they have, in comparison, a lesser appetite for sex. This is what is, and that is based on the testosterone being produced. And testosterone is produced, as I said, in women also in ovaries, and it is linked to exercise, whether it is male or female. Exercise increases testosterone production, and that is the key that I want to talk about in my talk. Before I talk theoretically, I get a patient from my clinic. This is a 60-year-old gentleman. So somebody talked about 60-year-old. He's a businessman, recent onset progressive erectile dysfunction, and he comes to me. I talk to him, he says, I scarcely go for my exercise. He has had one reading of blood sugar which was high 2 years ago. Then he stopped getting his blood sugar done because he thought he would get scared to look at the blood sugar, so he stopped getting it done. He was obese and hypertensive. And you know what he wanted was a quick fix for his sexual activities. He was a touring businessman, and he said, sir, I cannot go and perform when I want to, and that is my problem. So you give me something which is a quick fix. So obviously he was looking at something like sildenafil, and I insisted, no, this is not the right way to go about. I took the complete history and asked him for a battery of tests, which we very reluctantly underwent, and this is the actual report that I got on the third day. The glycosylated hemoglobin is 9, so his totally uncontrolled sugar. His testosterone is 189, and you look at his lipid profile, so everything is haywire. So what is happening is that, as Dr. Venkataraman has already mentioned, that once a person comes to you with erectile dysfunction, you have an ample opportunity to look at this guy and tell him, look, this is all that is wrong with you, and this is just a part of it. So the diagnosis does not stop here when you say, okay, I have diagnosed a hypogonadism, so your testosterone is low. The diagnosis doesn't stop here. We need to go further. We need to tell them that, look, this is how a male person should look like when he has got the peak of testosterone, which means that this is how the body should look like. And if the body looks like something like this, then perhaps the testosterone is low, which also means that all of you sitting here, if you capture this image in your minds, next time a person is walking into your clinic, you should be able to mentally assess his state of testosterone in his body, which means that more often than not you will be correct when you look at a person like this and get his testosterone done and find that it is low. So as Dr. Shivam Priyadarshi was talking about the drop in testosterone, yearly drop in testosterone, it is actually rather steep when it is beyond 50. So you shouldn't have forgotten that. So the drop in testosterone can be very steep. Now this curve can further be modified if you are sleeping not well, if you are not eating well, if you are not exercising, if you have a bout of viral fever. Somebody has got a chikungunya, he's got aches and pains, joint pains for weeks together. His physical activity drops. His testosterone is bound to drop. And then when he starts working, joints work again, he may not pick up his testosterone level at the same level as he dropped it. So every assault, whether it is a viral fever, whether it is myocardial infarction, whether it is an accident, road traffic accident, it can be a social accident, it could be a relationship accident, everything can drop the testosterone level, and the person may not be able to pick it up back as he dropped. So, as I said, it is produced even in the thecal cells of ovary, which is very important. He's already talked about it. This is important slide, so I'm repeating this part, that testosterone, whenever it is produced, it goes back as a feedback and has a negative effect on the pituitary and hypothalamus. Now, this negative effect is very important. For example, okay, I'll give you an example and then we talk about it. We leave it here. It is 1 to 4% free, is already been talked about, bioavailable. Somebody talked about free testosterone and total testosterone. Now, free testosterone is actually a very small amount. It is in picograms per milliliter. So what happens when you're measuring a quantity? For example, if you have to measure, say, onions, 10 kgs of onions, it is easy to measure because little bit of error may not be that significant. But if you are measuring gold powder, I'm not talking about gold, so you need a very sensitive scale. And look at what we are talking about. We are talking about picograms per milliliter. So that is the free testosterone. It is laborious, it is usually inaccurate, and that is the frustration. It is not easily available. A lot of time people will give it as radioimmunoassay, which is not, a lot of the labs are giving free testosterone as radioimmunoassay, which is not accurate at all. You should have a reverse equilibrium method. So if we don't have that, we would rather not get a free testosterone done. So what do? Suppose we don't have free testosterone, an easier commodity to measure is serum sex hormone binding globulin. If you have that quantity and you have total testosterone, we have these things on the net. You just put it, you go to this website of ISM, International Society for Sexual Sexual Medicine, and you can go there, you can click this, and you can find the calculator of bioavailable testosterone. It is the bioavailable testosterone which is more important. And then another thing, so somebody who walks into your chamber and you have a low testosterone, it does not mean that it is related to sexual activity. So there are various functions of testosterone, and there are various levels of testosterone on which it starts falling. For example, the testosterone falls to 430, then that is the first thing that happens is loss of libido. But he is still able to perform. At 349, the person starts adding a lot of fat, so he becomes obese. The testosterone is still normal, so you should understand how testosterone works. Then lack of sleep and concentration. So you have people, young executives who are insomniac, and once they are insomniac, they lose their testosterone further. But then if you are not able to concentrate, if you are having insomnia, maybe the testosterone is already fallen. And at 230 nanograms, you will have erectile dysfunction. Now, a word about how testosterone works with erectile dysfunction is that I'll give you an example. Suppose you have a hand pump. Now, you have a hand pump. I used to have when I was a child. We used to have a hand pump, and my job was that every Sunday I used to oil it. So if I don't oil it, what is going to happen? So you stop oiling the hand pump, it will still keep producing water. But after 3 months, one day it will just break down. So testosterone is the oil for erections, erectile function. So if you reduce testosterone suddenly, it is not going to make the person work immediately, fall immediately. As a corollary, if somebody has an ED and you give him a testosterone injection, and you expect that this night this guy is going to perform. I think if he performs, it is a placebo effect. It is not testosterone, because testosterone has a very intricate relationship with cavernosal muscles and cavernosal spaces, as Dr. Venkataraman has said. So it is very important here. I brought this slide because somebody who has just lack of libido, he may have a normal testosterone. So, but you should know where things are going. So I have, now there was a question, at what level would you like to start testosterone supplement? So this United States Endocrinology Society recommends that if the total testosterone is less than 300, that is when you should think of giving a testosterone replacement therapy. And this is in June 2010. Now, we all know, and Dr. Venkataraman has already mentioned, that once you replace testosterone in a proven hypogonadal man, which means that the person has a testosterone level of less than 300 nanograms. If it is more than 300 nanograms and you are giving testosterone, perhaps there are things which are not correct. Perhaps you are making more damage than good. But it does improve a lot of functions, including the metabolic functions, the glycemia, the lipid profile, the insulin resistance, to which normal human beings are not even aware. Many doctors are not even aware that that metabolic function is equally important. So they just come to you because of erectile dysfunction. So I go back to my clinic. In this case, I was waiting for you to discuss. So I get this person. He is a banker. He's 32 years male, married for last 2 years with his girlfriend. And these two people, this is a real case. Now these two people have been badminton players. And that is where he met this girl, started dating her, and got married eventually. And now he is a very successful banker. He works 12 to 14 hours a day, but he has not played badminton for 5 years. And his wife is still paying 4 hours a day. Now this is the discrepancy. So the appetite of the wife is still the same or even more, and this person is not able to perform. His semen count has dropped and his erectile function has dropped. So I get his tests done, and his serum testosterone is 265. My lab says normal is 270. FSH and LH are a little on the higher side, but still within range. Now, how many of you would like to give him testosterone at this level? He's just 32. They are looking for fertility. They are looking for, baby, and they're struggling. So anybody who wants to give testosterone, and why and what, and who does not want to give testosterone?
We'll check Siemens first.
No, semen is also one important thing we are talking. No, we will not. I have given you the testosterone level. Now, as I said, it is extremely important that we stick to the testosterone level once we decide, okay, we want to give testosterone replacement or not. But I'm glad there are people who said, get him the badminton racket. Yes, that is important, because if you give testosterone to this man, his FSH-LH, which is already on the higher side, that means it is struggling to push the testes to produce testosterone. They will suddenly drop, and his endogenous testosterone production will drop further. And once his endogenous testosterone production is dropped, his semen parameters are going to drop. So you are going to create perhaps azoospermia from oligospermia by giving testosterone to this man. And most important thing for this kind of person is lifestyle modification. So dangers of giving testosterone. I brought this patient here because it is important that we keep talking about theory, but this is the practical situation. Don't give testosterone, because once you give testosterone, FSH-LH will drop. He will go into testicular atrophy, because for testes to produce, for seminiferous tubules to produce sperms, they need a signal from follicle stimulating hormone, which comes from pituitary and hypothalamus. So these are the misconceptions that you look at a reading and you start treating these patients. I've already talked about it. Yes, so we need to talk about factors affecting testosterone: stress, high expectations, lifestyle. And of course, if you don't use it, you will lose it. So I'm not advocating indulgence in or overindulgence in sexual activity, but shunning sexual activity. So I do have patients, I do have couples. I will tell you again a real story. This couple comes to me, they are dating since school. They get married, they are doing very well in their business, they are business partners, they travel together, but they don't have sexual contact. It's extremely strange. They come from a very influential family of South Delhi. And I'm surprised, how is it? And the girl is also very attractive, the boy seems to be absolutely fine, but then they say, no, we just thought we can delay it. So they do not have sexual intimacy at all. So if you don't use it, you will lose it. And now there is pressure, they're married for 5 years, and the lady says he cannot perform now. And he says, no, we never thought that I will be doing something like this to her. She's so close to me. So that is how he's talking. But the lady wants the baby. So apart from exercise, you can advise them on foods which can boost testosterone. There are certain diets, they're easily available on internet. Please go and get your list in your area, whichever you want. You can tell these people to take these kind of foods. Because it is important that not to give testosterone, when not to give testosterone even if the testosterone is low. So other things, as I was talking about what else can happen if the testosterone is low, that mood swings. So if the testosterone is low, there would be mood swings. There can be various spectrum of psychiatric disorders, memory deficits, psychosis, and they need to handle stress. Now I'll tell you a small example. There's a young boy who comes from office, young man who comes from office, and he finds some kids playing in front of his house, and he puts his hand in his pocket and takes out some candies and distributes them and walks out. The same man, when he's 60 and he comes home and he looks at the street kids playing in front of his house, he's so angry with them. He throws them out of it. He'll hold them. He will go running after them, chasing them, that no, you should not come close to my house. Now, this is what is the difference in the reaction. So, can you tell me what has gone wrong? One of them is fall in testosterone. You don't know what you are going to do when there is a situation where you don't know how to react, you will just overreact. And that is a very important thing. तो हम हिंदी में बोलते हैं उसको सठिया गया है. So सठिया गया है, the 60 years is very important. So you must sleep for 7 to 9 hours. There should be weight management, exercise, stress management, diet. These are very important before we prescribe testosterone to a 60-year-old man. When do we prescribe testosterone? So you should know, if somebody from pharma company which produces testosterone is sitting here, he will hate me because I have till now not even talked about when to prescribe testosterone. 2 examples, and I have told you not to prescribe testosterone. Well, we all know if we prescribe testosterone, this is what is going to happen. We can restore the sex drive, enhance energy, feeling of well-being, and blah, blah. Coming to the pharma, yes, preparations, there are oral preparations, injections. Injections can be simple injections of 250 milligram testosterone, which can be repeated every 3 weeks. The problem with injections is that it causes supraphysiological levels, and that hits the FSH and LH, as against oral and depot preparations, in which, and that is not detrimental to FSH and LH. That's very important. Then one can have subdermal implants, which are slow release, gels. The problem with gel is that you have limited space, so you cannot apply gel every day at the same place, more than say 7 days. So there is a problem. Then you can transmit this to a young child, female child, or a lady with whom you are in contact, and she can develop a hirsutism. There can be patches. Patches are good, but they can cause irritation and allergy. Buccal tablets. People can put it like pan, supari, they keep it in the buccal tablets. But again, the problem is prolonged use can cause buccal erosions, which are painful and which are scary to look at. Sometimes you go to an oral surgeon, he will say, I will need to do a biopsy. And then nasal spray. Nasal spray can cause epistaxis, dryness of mucosa, and that is not good. GI absorption of testosterone undecanoate is because it is through the thoracic duct, it does not go through the liver, does not cause the first pass metabolism. The risks are, if there is a person who has got polycythemia vera, it can cause worsen it. If there is some people can have breast tenderness, there can be skin allergies, skin patches, there could be acne, there can be it is not that it can cause prostate cancer, but I'll come to this because I'm running out of time. These are absolute contraindications: CA breast, CA prostate, obstructive BPH, untreated obstructive BPH, obstructive sleep apnea, polycythemia, severe heart failure. Somebody who's in heart failure, if you give testosterone, is likely to gain more fluid and die. And somebody who is desirous of fertility. These are misconceptions that it can accelerate the rate of development of BPH. This is absolutely big no. Somebody has a BPH which is not causing a trouble, he will continue to have a progression of BPH over the years, irrespective of whether you give him testosterone or not. So giving testosterone does not worsen the BPH. Yes, but if somebody has an obstructive BPH, he's already got an obstruction due to his prostatic enlargement, you give testosterone, it's not worth it. You have to treat him anyway. You have to treat the BPH. Once you have treated the obstruction, you can give testosterone. So there is a study which says, that if you give testosterone, the IPSS score does not worsen. The voided volume does not change. The post-void residue does not change. Only the size of the prostate may increase, but that can increase even without giving testosterone. CA prostate is an absolute contraindication. Post-radiotherapy, post-radical prostatectomy, if for 2 years the PSA is undetectable, it can be started, but then it is again a very guarded treatment. So if somebody whom you are giving testosterone, 60 years male, you have to have a protocol. You have to do a DRE, digital rectal examination, to exclude CA prostate. You have to do PSA, ultrasound, and you have to follow up this at 3, 6, and 9 months, because if there is a sudden increase in the PSA, that means there is an occult cancer which has flared up, and you must stop testosterone, do the biopsy, catch the cancer, and treat it accordingly. Drug interactions are very important. Somebody who is in warfarin can start bleeding if you give testosterone. There can be increased hepatotoxicity with certain drugs. There can be, if you give testosterone to a person who is on antidiabetics, having glimepiride or chloropropamide, then they can go into hypoglycemia. I've had a man who went into hypoglycemia the day I gave him the testosterone because he had one of these drugs. So this is a personal experience. I learned it after that, but it is important. Somebody who is on thyroxine, he can have hyperthyroidism kind of picture. Somebody who is on calcitriol can have hypercalcemia. And there are a host of other drugs which can cause hepatotoxicity. So with this, I come to the end of my talk. And if there are any questions, I'll be very happy to answer.